Okay, so I'm here to talk about a little bit about the value of transformative medicines. And what I wanted really just to do very, very briefly was just show some, it's mostly numbers really, that shows a little bit about particularly the hospital drug specialty sector and how that is growing, and whereas it's bringing some very transformative changes in outcomes for patients, it's also bringing with it problems in funding, problems in affordability. And at the very end, a little bit of a suggestion as to how that might be tackled, both from the funding end and also potentially from the manufacturer's end. I believe that there are representatives of both the healthcare providers as well as the manufacturers of some of the drugs in the audience. So hopefully some of this will resonate. What I'll do is we're focusing mostly on orphan drugs with a particular focus on cystic fibrosis as a sort of case study. So just to start off a little bit of context, some numbers for the Netherlands. A lot of numbers here, not all of them important, but just to show you that the healthcare spend, which is the number here, is growing actually at a faster rate than GDP. So although you're spending at the moment around 11% of your budget on 11% of your GDP on healthcare, it's actually growing at 3 times the size. But interestingly, the drug spend is only growing at around the same rate, at around 1%. A little bit of a caveat. So some of our numbers, some of the numbers that you will see, come from sales data that is not necessarily wholly complete. So whereas I'll put that little caveat on some of the numbers, this is certainly the trends are fairly accurate, but some of the absolute numbers may be slightly off. Also interesting is that the orphan drug spend is growing at 38%. And I'll show you some figures in a little while that shows you just quite how much over even just the last 5 years, the numbers of orphan drugs that have come onto the market are exponentially increasing. And then we will look specifically at CF spend, and that's beginning to grow. And there's one drug out in particular and a number of drugs in development which will absolutely massively increase the amount of money that is spent on CF patients, dwarfing the other costs of looking after them. Very, very much dwarfing. And there's obviously a question about, well, what exactly are we getting out of those medicines and how do you go about funding those? So, next slide. So again, this is also just showing that the orphan drug spend and the CF spend, they've been growing above the market average over the course of the last few years. And you can see here, really, this is just a graphical example of how, if you look at orphan drugs, they are now massively taking off in terms of growth. Now, in Europe in general, and it's a little bit difficult to measure because orphan designations vary from one country to another, but it's been fairly constant up until around 2014. At around 4 to 5% of the drug spend has been on orphan drugs. And it is quite possible, given what we're about to see, that could quite easily double before 2020. And I'm sure most of you in the audience know about orphan drugs, but really this is just to show that actually, orphan drugs very often bring a huge amount of value because you're talking about very small patient groups with very high unmet need. Very often, orphan drugs are being launched where either there is nothing available or there are older drugs available, maybe drugs that are used off license. They are certainly able to completely transform a patient's life. When we look at CF drugs, you'll see that certainly one of the newer drugs has had an effect like no other drug has had before. The environment for introducing orphan drugs is also quite favourable compared to other drugs as well. So there are lots of regulatory, once you've got orphan drug designation, there are lots of regulatory incentives to develop the drugs, to launch the drugs, to gain extra exclusivity. And also when you look at payers, particularly around Europe, their threshold for assessing orphan drugs very often is different to the threshold that they would use for other drugs. The one thing that we do notice is that the speed of access can sometimes be quite different. So if you look at Germany and the UK, you very often get very quick access to the drugs there. Other countries, notably Spain or Italy, can take a long time, sometimes up to 2 years and even more, to approve some orphan drugs, very often because of that affordability issue. When it comes to pricing, you will no doubt, especially those of you who are procuring drugs in the audience, there may well be some of you, will have noticed that you're starting to see numbers, and maybe when you started in your profession, you never saw those numbers before. And we'll look at one in particular in a few slides' time. But we've got an example here, actually, that in the Netherlands, Sanofi's drug for Pompe disease, Myozyme, has been 700,000 euros per year, and that is now being negotiated down quite heavily. There are other national and across Europe initiatives in place. Certainly there's a lot more sharing of price information across European states, and in the Netherlands and Belgium have also been sharing some procurement of drugs. I think Sovaldi is an example of that. And so just to look at the last few years, and you can see these are numbers of orphan drugs, with this colour being the oncology orphan designation, and these being all other TAs. You can see that oncology is actually a very large percentage of all orphan drugs that are launched, and you can see how we've more than doubled the number of orphan drugs that are launching each year. And in terms of financial impact, here is the impact for the Netherlands, from 15 to 54 million in just a 5-year period. So we're talking about really, really high impact, and many of the drugs having and bringing outcomes that patients have never seen before, but clearly there needs to be some sort of discussion about value and about whether some of these amounts are in fact sustainable over the course of time, particularly if this rate of new launches continues, what was a barrier of 4 to 5% of overall drug spend is very clearly going to be smashed through. And so here are some examples of some of the orphan drugs that are going to be launched just between now and 2020. This is not by any means a comprehensive list. These are some of the ones where what we've taken is some financial data from mostly from business analyst reports, to show that some of these individual drugs for very, very small patient numbers could have an impact of 1.8 billion in this case as a global hit, which if you think for a single drug that might only be treating potentially even just a few hundred patients, that is an enormous sum of money. And you can see that there's still many, many cancers mentioned here, as well as even some areas where there are other orphan drugs available. I mean, some of the areas, like for instance pulmonary hypertension, is now actually quite a crowded space. One might start to ask the question about what new drugs are actually adding when there are already maybe 6, 7 orphan drugs available. So just to take a brief look at the timeline for cystic fibrosis, and in particular what happened when Kalydeco launched. I don't know if any of you are familiar with this particular drug, but cystic fibrosis is a hereditary disorder. If you are born with it, the median lifespan in Europe is around 40 years of age. Most many organ systems are affected, but predominantly it's the lungs and the gastrointestinal system, and it's all to do with a mutation of a particular transmembrane protein that doesn't quite function in the right way. There are different genotypes and different subclasses of the disease, and it is and although it's an orphan drug, you know, there are many thousands of patients, tens of thousands of patients around the globe. It's mostly found in it's a Celtic gene, so where you find Celtic populations. So the US is the biggest market simply because it's obviously there's 230 million people there. But interestingly, the second most prevalent market is the UK. The Netherlands has, I wrote it down on a piece of paper, which I left here, and I can't remember what it was, but I think it's about 1,400 patients altogether. Thank you very much. Yeah, 1,403 patients, that's fine. 1,403 patients for cystic fibrosis. Now, Kalydeco, which was launched here in October 14, only treats a very small subpopulation. Those with what's called the G551D type. And the number of patients for Kalydeco that are appropriate for Kalydeco in the Netherlands is only 37 out of that 1,400. So when you see some of the numbers for Kalydeco, just remember that the most patients that will treat is 37. So here are some numbers. Now these show, first of all here, that the average cost of care for CF patients, these are the total costs before Kalydeco, so that includes all their drugs, their hospital care, their outpatient costs and everything else, is around 30,000 euros per year for each of those 1,400 patients. And the estimated, before Kalydeco came, the estimated total amount spent on cystic fibrosis patients is 40 million. And then when you think that just the first year of Kalydeco, I don't know how many of those 37 patients were covered, there's already 6 million spent on Kalydeco. So given that 30,000 is what we were spending before Kalydeco on a patient, does anybody here know the list price of Kalydeco in the Netherlands? I'm looking at my crib sheet, 248,000 euros. So, certainly getting on for 10 times that. I'm sure that the net prices are a little bit lower. I don't know how much lower. We're not allowed to know the net prices. But you can see that at some point you have to ask yourself, well, what does this bring that the other drugs don't bring? For those of you who know anything about cystic fibrosis, as I say, it's mostly, most of the way it presents is a rapid decline in lung function, which gets worse with each exacerbation. So a CF patient will have very clogged up lungs full of very thick sputum, and every time that is assaulted by, say, a chest infection or other sorts of lung trauma, their lung function declines and declines and declines until they essentially can no longer breathe and they die. Very often, as I say, very often happens by their mid-20s, but some may live until they're about 40 years of age. Kalydeco treats one of the more severe forms, and the improvements in FEV1 with Kalydeco were out of the ballpark of anything else that has ever come out. So that's improved FEV1 by 10%. And although it's not been out for very long and still some prospective data is being collected, some modelling suggests that it could potentially halt some of the lung degeneration that goes on. So this could be, although it's far too early to say, this could be the beginning of a hint towards disease modification, which has never happened in cystic fibrosis before. We've always treated it symptomatically and palliatively. And so for just looking at the numbers here, you can see that what was around 22 million in CF sales will now increase to around 40 by when you include Kalydeco by 2020. And then the next drug, which is Orkambi, which treats 511 patients in the Netherlands, based on maybe 2/3 of them getting it, raises the total bill from 20 to 100 million euros. Now, so it's not exceptional that healthcare systems have adapted to very large increases before. And this is really just to show that although the numbers the overall budget impact may well be smaller, you can see that, when we've come from a low-cost base, as we did when we introduced the new oral anticoagulants, or when we introduced the new drugs for HCV, there have been very, very big step changes in the amount of money that have gone in. I mean, here we've got a total budget impact of 74 million in 2015 for the Netherlands. And that, as you know, that probably only represents a very small proportion of the overall HCV population. So there is a history of healthcare systems absorbing some of these costs and having to increase the amount they put in, as well as increasing efficiencies to try and absorb the extra increase in drug costs. But as I said, there needs to be, I think, a particular open conversation about the actual value that the drugs are bringing. Because as well as orphan drugs, there are a number of other drugs that are coming out for non-orphan indications that are also bringing with it very, very big bills. So you can see here a number of a broad range of diseases where you've got worldwide impacts of many, many billions. So a little bit onto the funding. There are ways that some European countries have already handled some of the funding issues, or tried to handle some of the funding issues. One of them is to agree things at a national level. So in the UK, about 60 specialist areas and their drugs and the services associated with those are commissioned and purchased at a national level. And that allows there to be some negotiations, some fairly tough negotiations on net prices in particular of some of the drugs, because essentially there is one customer for the drug company. Where that doesn't happen, there's also some risk sharing across regions, so that an individual patient, or maybe just a small number of patients, don't make an inordinate impact on any one hospital or on any one region. Another proposed model of funding is an annuity model, where it is possible to pay in installments, or even potentially to risk share with the manufacturer as well. So, for instance, there's a number of examples where a 1 year of therapy may well be set at, say, 7 months, and you pay for a year, and then if the patient lives longer than 7 months, you have benefit, and obviously you lose if the patient lives less than 7 months. The ability to capture real-world data and the increase in patient registries, particularly for diseases that have small numbers of patients, have allowed a fair number of pay-for-performance contracts. I don't know about the Netherlands in particular. These are quite favourable in the UK and in Italy, where in Italy oncology drugs are purchased this way almost routinely, where the amount that you pay for the drug depends on the outcomes for individual patients. But that's obviously dependent on being able to capture the data on those outcomes routinely, and very often that's not done in every healthcare system. Some healthcare systems, like for instance the German healthcare system, actually does not allow that information to be shared, and therefore real-world data is very, very poorly used in Germany, simply because the legality of using it is very difficult. Again, so just to summarize some of those issues then, we have a new situation with orphan drugs. So what was a group of drugs that would take around 4% of the budget is now set on a trajectory potentially to go to 8 or 10%. And that amount of money is going to be spent on relatively small numbers of patients. That there are other future drug pressures that we've accounted to reach potentially around 95 million by 2020. Again, we've got lots of caveats to that number, but it's a reasonable estimate. Cystic fibrosis itself could well add up to 79 million of that just on its own. And another little exercise that we did was also to look at some potential ways of putting efficiencies in the system. We looked at, for instance, just what might happen if the non-generic prescribing was switched to generic. That could save up to 14 million, and there is an estimate from a study that says around 100 million could be saved in just wastage. So there are things to take off the other end, but as you can see, probably not enough. There is a question then, and this is potentially a question for the industry, which is if you're bringing drugs that have undoubted benefits for patients, and you're bringing essentially a pharmacological solution to a medical problem, you may also be bringing other problems along with the solution, which is obviously the problems of funding and affordability. And the question that we have posed, and we're working with a couple of industry partners on this, is whether in fact there is a way of engaging with hospitals and with hospital payers in a new way, and whether there is potentially a new business model, particularly around the introduction of these very high-cost drugs. And some of these lessons come from other industries. Some industries quite aligned to the drug industry, where the industries have developed over the last few years from moving from a purely transactional model, where essentially you are the provider of a commodity and the purchaser buys your commodity, to a more transformative relationship where you become part of the delivery as well as and part of the problem solving as well as the provider of a product. And an example that we've taken from a very, very sort of closely aligned analogous industry, GE are a company that, amongst other things, they make some of the big machines that you find in hospitals like these. MRIs, CT, PET scanners, some of them almost as expensive, if not even more expensive than some of those drugs that we saw earlier. And what GE have done over the last 5 to 10 years is created a separate organization or separate part of their organization that comes and solves hospital-related problems. So as well as being a provider of kit, they've also launched a number of projects where, for instance, they've improved the capacity management within a hospital. Better manage the length of stay, enhance staff satisfaction. Essentially what they did was they procured, or they merged with a number of provider consulting organizations and essentially provide consultants that now work with hospital managers and with some of the decision makers within large hospitals or large groups of hospitals. And they've had amazing results in terms of the way in which they've improved some of the efficiencies within the hospital. But what's also interesting from a GE business perspective is that they've been able to sell their product into more hospitals than they did before. So places where, for instance, maybe they were hospitals were partnering with Philips or Siemens are now partnering with GE. So it's a possible solution for the manufacturers or the representatives of the manufacturers that are in the audience, that part of the way in which you sell in to hospitals with the drug, as well as providing the problem of funding, is that you bring some solutions as well. So I tried to keep within the time that I was given. I hope that I managed to do so. I think that what is coming, hopefully that set a little bit of a scene for some of the other discussions that are a little bit more detailed, but I'm happy to take any questions.